lecture we'll be discussing infertility issues. In preparation for this lecture, I would highly recommend that you review the menstrual cycle and ovarian cycle lecture. During this lecture pertaining to infertility, we'll be discussing the following issues: essential components of fertility, physical and psychosocial issues, assessment of female and male fertility, methods of managing infertility, legal and ethical issues, adoption, and nursing care for these patients. Infertility is defined as the inability to conceive after 12 months of frequent unprotected intercourse. So what are the statistics? When do we expect people to become pregnant after having frequent unprotected intercourse? The statistics are that women up to age 25, 60% of them will conceive within 6 months and 85% within 1 year. So infertility affects about 10 to 15% of couples in the United States. What causes infertility? 40% of the time there could be a female factor, which we'll be discussing. 20% of the time, a male factor. 30 to 40% of the time, here's where it gets complicated, there's a combination of factors between the male and female, or it's unexplained. We are seeing more people delay childbearing, so with increased maternal age, there can be an increase in infertility. Also, weight can cause an issue. Sexually transmitted infections, stress, and smoking are all factors that can contribute to infertility. During an initial investigation, we generally go from least invasive to more invasive. We'll obtain a comprehensive history, both the female and male. We'll ask them, is intercourse taking place regularly? When is intercourse taking place? These are great teaching opportunities. We can teach them about their cycle, ways to acknowledge ovulation is taking place, and the most fertile days as discussed in the contraception lecture. We'll also look to see if they're using alcohol or smoking, since we know that these interfere with fertility. And we want to note that couples can often be very emotional about this. It can be difficult for some patients and couples to discuss sexuality or go for an intervention such as fertility intervention. And the inability to conceive can also be very emotional for the couple. So we want to advocate for them and really establish that trusting relationship with this couple. Couples seeking help for infertility have great teaching opportunities for us as nurses. What do we want to tell them? What should they know? Should we assume that they know everything? No. We want to kind of start at the beginning and start in manageable pieces. As I said, infertility is inability to conceive within 12 months of frequent intercourse. What does that mean? The answer is they should be engaging in intercourse every other day if they want to become pregnant. We should tell them if she has a regular cycle that is normal in length, that cycle days 7 through 17 are most fertile. So definitely, cycle days 7 through 17, they want to be having intercourse every other day during that period of time. She should avoid douching, as this can wash sperm out, and also the use of lubricants, because that can pose as a barrier for the sperm getting to the egg. We should tell her that she should attempt to retain the sperm following intercourse. So if she's laying in a supine or recumbent position, avoid getting up to go to the bathroom or take a shower, and she should do this for about 20 to 30 minutes. Some women will actually elevate their hips or prop them up on a pillow as well. This is a great time to initiate prenatal vitamins and talk about a healthy diet, especially since weight can be of concern in couples with infertility issues. We want to talk about stress alleviation. This can be really stressful for couples. This can affect their relationship. This can affect their ability to work sometimes. So we want to talk about stress alleviation. And it can make the act of intercourse almost a project because they're so focused on getting pregnant. Also, as we move through further assessment of the infertility issues, we may want to talk to them about other interventions, medical interventions. And we'll talk about these as we go through the lecture. We want to do this in a way that's open and meaningful, and then advocate advocate for what the patient wants. So we need to do, our intervention should encompass also what they find acceptable. When assessing the fertility of a woman, we'll first consider ovulatory factors, since they are the cause of 25% of infertility. So this is quite significant and worth investigating. We will ask the woman to track her basal body temperature as we discussed in the contraception lecture. So what does she see, if you'll recall, at the time of ovulation? She sees a spike in her temperature. So this would indicate to her that this is a good time to be having intercourse. And it also tells us about her ovulation status. Is she ovulating? Is she not? This might be a good indicator that would allow us to do further exploration. We would expect an order to test some gonadotropins, FSH, which stands for follicle stimulating hormone, and LH, luteinizing hormone. FSH, follicle stimulating hormone, should be measured at cycle day 3. This is the most valuable test in assessing ovarian reserve, or the number of oocytes or follicles in the ovary. So this is very helpful. LH, we would typically see an LH surge, luteinizing hormone surge, on the day of ovulation. So we would expect daily sampling of LH at mid-cycle to see that she's having an LH surge. That elevation in luteinizing hormone, again, tells us that she's ovulating. They also make home LH indicators. Women can use these to see if they are ovulating when they're having their LH surge. It's a urine test that would give a positive indication, and she would know then that that is a fertile day and should engage in intercourse. We'll also be testing progesterone. Progesterone gives us an idea about the evidence of ovulation taking place. So we'll expect to draw this on about day 21, or 7 days after we believe ovulation has occurred. Again, this generally indicates an adequate luteal phase, telling us that she is ovulated. Prolactin is a hormone that, if present, can frequently cause ovulatory dysfunction if it's too high. Prolactin also has a role, if you'll remember, in breastfeeding. Here we're looking for high levels of prolactin that could be causing ovulatory dysfunction. Thyroid stimulating hormone. TSH stimulates prolactin secretion by the pituitary gland. Hypothyroidism, low thyroid level, can have a dramatic effect on ovulatory function and can cause irregular cycles and bleeding irregularities. So thyroid stimulating hormone is also helpful. And we'll look at androgen. We often associate this with testosterone. This can also cause ovulatory dysfunction. Sometimes these women will report oligomenorrhea or anovulation due to amenorrhea, no period at all. So these are some of the labs that we would expect, and we will also be asking the woman to record her basal body temperatures. These are tests related to ovulatory function. Cervical mucus can also be assessed. We'll note some cervical mucus changes. These are caused by estrogen as ovulation approaches. Spinbarkite, if you'll recall from the contraception lecture, is when mucus becomes much more elastic, and this indicates impending ovulation. We can also see ferning. If you get some cervical mucus that you put it on a slide, allow it to dry, and look at it under a microscope, you see this ferning pattern. And you can see this on the photo on the left. It's the crystallization of dried mucus when looking at it under a microscope. So this is also a nice review. You can see how the cycle does carry over from contraception to infertility, so kind of the other end of things. So it's nice, though, to have the review. We're not done with the discussion of cervical mucus just yet. Some women produce inhospitable mucus. That means that the mucus does not allow the sperm to pass through it to get to the egg. Other women may produce anti-sperm antibodies. These immobilize the sperm so that they can't move to where they need to go. Ideal cervical mucus should be thin to allow the sperm to get through, clear, watery, profuse, and alkaline. So it can also be a problem if it's too acidic. In cases where the mucus is a problem, they may perform measures to eliminate mucus, medications, or removal of some of the cervix, or they may perform intrauterine insemination, which we'll be discussing. An endometrial biopsy is a procedure in which a small catheter is placed through the vagina, through the cervix, and into the uterus, where a small sample of the endometrium is removed. This provides information about the receptivity of the endometrial lining, how likely it is, that is, for pregnancy to attach and grow, and it also gives us some idea of what's going on with progesterone after ovulation. During a transvaginal ultrasound, the ultrasound probe is placed vaginally, and the ultrasonographer provider can then look at the screen to assess the development of follicles, which are maturing eggs, or endometrial development. This is indicated for patients who are going through ovulation induction. We're giving them medications to enhance ovulation, timed insemination. If they're going through intrauterine insemination, we want to make sure that they're ovulating when we do that, or if they're timing intercourse related to ovulation. They'll also do this with a patient who's going through in vitro fertilization to check on the maturity of the follicles and see if they're ready for harvesting, which we'll be talking about. This is also the type of ultrasound that's done very early on in pregnancy. If you remember, the best dates, the most accurate dates of a pregnancy are those that are obtained early on in the pregnancy. So those that are around 5 or 6 weeks or so are dated using a transvaginal ultrasound. After evaluating ovulation and cervical mucus factors, if nothing has come up, the assessment of infertility will continue. Next, the uterine structure and tubal patency will be considered. A hysterosubpingogram is a test in which dye is placed into the uterus and the uterine structure and fallopian tubes are observed. Here you see two different results of a hysterosubpingogram. One, you can see the open fallopian tubes in the uterus. In figure 2, you can see that the tube on the right is blocked. So you wouldn't be asked to interpret this, but I always think visuals are helpful in determining exactly what it is that we're talking about. This is a hysterosubpingogram. A hysteroscopy allows for further assessment of the size, shape, and location of the uterus and a better look at the uterine cavity. Here, the provider may see polyps, little outpouchings coming out from the uterus. They may also see fibroids, non-cancerous tumor-like growths in the uterus. Occasionally, they may also be able to take care of these or excise these during the hysteroscopy. A hysteroscopy is typically performed after a hysterosubpingogram. Here, as you can see, a speculum is placed in the vagina and the hysteroscope is placed through that to allow the provider better visualization. A laparoscopy is an outpatient surgical assessment where the pelvic organs can be visualized. You'll see that gas is placed in the abdominal cavity, and this allows the provider to look at the pelvic organs. You can see the uterus, ovaries, fallopian tubes. They can assess for endometriosis. This is endometrial tissue or uterine lining outside of the uterus that can sometimes cause problems with infertility. Are there adhesions? Occasionally, after a patient has an abdominal surgery or if she's had a prior C-section, tissue can grow adhesions. They'll also look to see, does she have PID, pelvic inflammatory disease? Presence of tumors and cysts are also looked for. Assessment of potential male-related infertility issues begin with the assessment of structure and function. Potentially, the male may have a varicocele. This is dilation of scrotal veins. This accounts for about 40% of male-related infertility, so generally this is a great place to start looking. Also, the male may have testicular atrophy. This could be to prior illness. Prior viruses can cause this. Absence of vas deferens. Some men are born with absence of vas deferens, so there's no route for the sperm to make it to the ejaculate. Therefore, it leads to irreversible infertility. A semen analysis is an assessment of the male semen. We look at a couple of things and look at their values to assess male fertility related to the semen. One of them is volume. The amount in an ejaculate should be greater than 2 mLs. The pH should be between 7 and 8. We don't want it more basic or more acidic. Sperm count should be greater than 20 million sperm per ml. Liquefaction, the time that it takes the semen to completely become liquefied. This should be complete within 1 hour. As far as motility is concerned, we expect 50% or more of the sperm to be moving in a forward direction. And we expect that 30% or greater of the sperm are of normal form. This is a semen analysis. In order to obtain the sample, we ask the man to remain abstinent for 2 to 3 days so that the sample is adequate to consider all of these factors. Some important terms related to semen analysis are included on this slide. Oligospermia. If you think about this name, oligo means low, sperm. So this is semen with a low concentration of sperm. It might not be adequate for fertility. Azoospermia. This is impaired or non-existent sperm production, so this could certainly lead to infertility. It should be noted that those with oligospermia and azoospermia are also at greater risk for having offspring with genetic mutations. Some individuals may also form anti-sperm antibodies. This is often due to impairment in the blood-testes barrier, such as a testes torsion, or twisting of the testes, an injury, or reversal of a vasectomy. Let's look at management of infertility. As far as pharmacological agents go, Clomid is often a first-line defense. This induces ovulation through stimulating the hypothalamus to produce gonadotropins, FSH, follicle-stimulating hormone, and luteinizing hormone. This may be combined with the use of an LH indicator, where the woman would look for her LH surge, indicating ovulation, or basal body temperature regulation. This may also be combined with timed intercourse, so when she believes she's ovulating, she would have intercourse, or intrauterine insemination if there's something else going on with the cervical mucus or so forth. Another class of medications used for management of infertility are gonadotropins. Brand names include Repronex, Menopur, Follistim, and Gonal F. We are actually giving the gonadotropin in the injectable form. So these contain follicle-stimulating hormone and luteinizing hormone. The hope is that the ovaries will develop follicles. These are typically used for anovulatory women who have low or normal levels of FSH and LH. Also, patients who didn't conceive with the use of Clomid will graduate to the use of gonadotropins in the world of infertility. Typically, they'll go for about 6 cycles with the Clomid prior to going to the injectable gonadotropins. Patients who are undergoing assisted reproduction, like in vitro fertilization, will oftentimes be on gonadotropins as well. There is an increased incidence of multiple gestation. For patients who are on gonadotropins, there are some special concerns. They need to be monitored closely for hyperstimulation or multiple pregnancy. Well, how do we monitor this? Hyperstimulation would be when the ovaries are hyperstimulated. So there's hyperstimulation. The concern is, will she have too many follicles developing? Is she at risk for multiple pregnancy and some other issues concerning hyperstimulation? A transvaginal ultrasound would be performed by the ultrasonographer or provider to monitor follicle development. Once the follicles are seen and mature, a dose of HCG, human chorionic gonadotropin, or the pregnancy hormone, is actually administered. And this encourages the follicles to ovulate, to become eggs and be released. In the case of natural circumstances where she'll be achieving pregnancy, hopefully through intercourse, we would advise her to have intercourse 24 to 36 hours after administration of the HCG injection and for the next 2 days. Some women may have a luteal phase defect. What is the luteal phase? Do you remember from the ovulation cycle? The luteal phase begins with ovulation. So if there's a luteal phase defect, this can be caused by poor follicle maturation, premature demise of the corpus luteum, or lack of endometrial response to progesterone. Progesterone's role in the endometrium is to build it up so it's nice and thick and rich for implantation of a pregnancy. Low progesterone levels, however, are associated with follicle-stimulating hormone in the proliferation phase. So, what can we do about this? We can give progesterone, which increases endometrial receptivity to implantation of the pregnancy. Typically, progesterone is administered after we give human chorionic gonadotropin for ovulation. Remember, if they will be on this phase of management for infertility, oftentimes they will be getting injectable gonadotropins, followed by human chorionic gonadotropin. Once the follicles are mature, we give HCG to stimulate ovulation. Now we're giving progesterone so that the lining in the uterus is nice and rich and thick for implantation of the pregnancy. Parlodel is another medication that can be used in the management of infertility. Parlodel inhibits the pituitary secretion of prolactin. There's an interesting connection here. High levels of prolactin are associated with decreased levels of follicle-stimulating hormone and luteinizing hormone, which are needed for follicle development and ovulation. So, inhibiting prolactin development then allows FSH and LH to remain at normal levels. However, we use this with caution if we believe the woman may be pregnant because it is teratogenic. Side effects of Parlodel include nausea, diarrhea, dizziness, headache, and fatigue. So we may need to kind of boost her up in her dosage of Parlodel slowly to avoid a large onset of side effects quickly. We may also see insulin sensitizing agents such as metformin being used in the management of infertility. Anovulatory women with polycystic ovarian syndrome, as the name indicates, they have multiple cysts on their ovaries, are often hyperinsulinemic. So giving them an insulin sensitizing agent can treat women with polycystic ovarian syndrome and allow them then to ovulate. Endometriosis, or the presence of endometrial tissue outside of the uterus, can be cause for infertility. So a pharmacologic agent for this is danazol. This suppresses ovulation and menstruation to allow for atrophy of the endometrial tissue that is outside of the uterus. Sometimes the woman may be on danazol for 6 to 12 months. This can be an emotional time for her because she's trying to get pregnant, but while she's on danazol, we're actually suppressing ovulation and menstruation. However, what we're trying to do is allow that endometrial tissue that's outside of the uterus to settle down so that she can become fertile after treatment with danazol. Also, with a patient who has endometriosis, you may see the use of oral contraceptives to try to let the endometrial tissue settle down. Let's review frequently administered medications to manage infertility. Clomid is used to stimulate and release eggs through stimulating the hypothalamus to produce FSH and LH. This is a PO medication. Gonadotropins directly stimulate follicle development by giving FSH and LH. This is given in an injectable form. Once patients have mature follicles from the use of gonadotropins, HCG is given to trigger ovulation. After intercourse or in vitro fertilization, progesterone is given. Progesterone prepares the endometrial lining for the pregnancy and helps maintain the pregnancy. This can also be given to women who have a luteal phase defect. Parlodel inhibits secretion of prolactin. Excess prolactin decreases FSH and LH production. So if we can inhibit secretion of prolactin for these women, it allows for adequate production of FSH and LH so that she can ovulate. Danazol can be used for women who have endometrial tissue outside of their uterus. This is called endometriosis. Metformin can be used to help control hyperinsulinemia in women who have polycystic ovarian syndrome. This is a summary of the medications frequently used to manage infertility. Another way of potentially managing infertility is through the use of therapeutic insemination. This used to be called intrauterine insemination or artificial insemination. This is where sperm either donor sperm or the partner's sperm, are washed and then placed at the woman's cervical opening. This may take place with her natural cycle if she's ovulating on her own, or with ovarian stimulation. It just depends on the rationale and the reason that the couple's having infertility issues. So if she is ovulating on her own, this can be timed with her natural cycle and done at around ovulation time, or she can be taking medications that we've discussed, and this would be administered with that at the time of ovulation. Rationale: why would we think that therapeutic insemination might be a good choice for a couple? Male factors include low sperm count, impaired motility, and abnormal morphology. So you can see here, if you look at this picture, we are placing a small catheter to the end of the vagina near the cervical os or cervical opening, and then injecting the sperm right there. So with these sperm issues, we can really give these sperm a fairly good chance. We're doing this at the right time in the cycle. We are washing it so that they have as few barriers to get through as possible. And then we're injecting right at the cervical opening. Female factors that might make therapeutic insemination a good choice for attaining pregnancy include scant or inhospitable cervical mucus. This would make it difficult for the sperm to get through the mucus to get to the egg, or cervical stenosis, narrowing of the cervical opening that might make it difficult for sperm to get through. Donor sperm can be used in therapeutic insemination in cases where there might be problems with the quality or quantity of sperm. Perhaps there's a genetic mutation. Maybe they're not swimming effectively, or there aren't enough for a pregnancy to take place. Maybe it's a single woman who desires to have a child, or perhaps a lesbian couple. A donor can be a known donor or an anonymous donor. There are some ethical and legal concerns here. Informed consent is obtained by all parties, and of course the donor has no legal right to the child. A very, very thorough medical and infectious disease screening is done to prevent transmission of genetic defects, sexually transmitted infections, and let the parents know a little bit about the donor. This would include things like their educational background, their heritage, how tall they are, the color of their hair and eyes. It also gives their medical history and a genetic history of things that are within that person's family. Another concern is the number of pregnancies that might come from a donor. If it's a desirable donor, although rare, there may be several children out there who have the same biological father. What happens if two of them were to meet up and wanted to have children one day? Again, that would be very rare and unlikely, but that question has come up. Donor sperm is frozen and quarantined for 6 months to ensure safety. In vitro fertilization, or IVF, is assisted reproductive technology. In vitro fertilization, eggs are extracted from the ovaries and are fertilized with sperm in a laboratory, hence the name in vitro fertilization, or in vivo fertilization, in a test tube or in a lab dish. Embryos are then transferred to the uterus 1 to 5 days later. If you look at the picture here, starting at the lower left, you'll see with ultrasound guidance, eggs are aspirated from the ovaries, working through the vagina. A woman is typically sedated during this. So eggs are removed. They are then mixed with sperm. 1 to 5 days later, viable embryos are then transferred to the uterus. Rationale for performing in vitro fertilization includes infertility related to tubal problems, cervical mucus problems, cervical problems such as cervical stenosis, male infertility, or immunologic infertility. For many patients, this is kind of a last resort effort. They've tried Clomid, they've tried injectables, now they're moving to in vitro fertilization. This is a very emotionally and financially expensive experience. Many times patients are very emotional about this. They've had a history of ups and downs with attempting to get pregnant. And also, financially, many insurance companies do not cover in vitro fertilization. Some don't cover any infertility treatment at all, so this can be very, very expensive, in the tens of thousands of dollars. Following in vitro fertilization, what are the implications of embryos that exist that weren't placed? Embryos can be cryopreserved. This is how we store excess embryos. In the future, they may be thawed and used. Maybe she doesn't get pregnant with this cycle. Maybe in 3 years she desires more children. Generally, another ethical issue is, how many embryos do we place? The patient wants the greatest chance of achieving pregnancy. However, there are risks associated with multiple gestation pregnancies. So typically, the agreement is 3 to 4 embryos offers the greatest chance of achieving pregnancy while balancing the multiple pregnancy risk issue. What are some legal and ethical questions concerning embryos? There are many. Again, the concern with placing more than 4 embryos could be placing the mother at risk or all of the fetuses at risk. Another question is, who has legal custody of the embryos? What happens in the case of death or divorce? How long can embryos be frozen for? Or what do we do with them if a family is done having children? To answer this question, some patients will have them placed in the uterus at a time when they're not likely to get pregnant. And what about embryo donation? Donating embryos to couples who might not be able to have embryos. Maybe they have a genetic mutation. Perhaps one of them doesn't have the ability to give a gamete. Maybe they had their ovaries removed or don't produce sperm at all, for example. These would be cases for the potential of embryo donation. A gamete intrafallopian transfer, or GIFT, is a process in which eggs are collected with ultrasound guidance, again, done transvaginally. A needle is placed through the vagina to the ovary. Eggs are collected. Then, eggs and sperm are transferred in the fallopian tube separately, with the hope that conception will take place now that the egg and sperm are both together. So fertilization is not taking place in the petri dish. Fertilization is taking place in the fallopian tube. A gift is often more acceptable in some cultures and religions such as Catholicism because the actual conception is taking place within the woman's body. A zygote intrafallopian transfer is a procedure in which eggs are collected with ultrasound guidance. The eggs are then fertilized with sperm in the laboratory, and then zygotes are transferred into the fallopian tube. How does this differ from in vitro fertilization? With a ZIFT, the zygote is being transferred to the fallopian tube. In vitro fertilization, they are placed in the uterus, so that's an essential difference. Another question. When considering the differences between a gift, the gamete intrafallopian transfer, and the zygote intrafallopian transfer, which do you think more often leads to pregnancy? The ZIFT, because we know that fertility and the sperm and egg meeting has taken place. With a gamete intrafallopian transfer, we're merely putting the eggs and the sperm in the tube. They're close together, they're in the right place. So it may very well happen, but certainly chances are much greater with a zygote intrafallopian transfer. We know that conception has taken place. Just as men can donate sperm, women can donate eggs, or oocytes. Donor oocytes are the use of donor eggs, and this is often done due to premature ovarian failure, removal of the ovaries, advanced maternal age, prior use of chemotherapy, genetic disorders, or oocyte defects. So these women are good candidates for the use of donor eggs. This can be a known or anonymous donor, and again, extensive genetic and medical screening is done. If this is an anonymous donor, typically, again, there is a background that's done so that the couple knows things about the woman who is donating the eggs, such as her genetic heritage, height, weight, hair color, eye color, and genetic familial history. Donor eggs are then fertilized, typically with the partner's sperm, and then are placed in the uterus through in vitro fertilization. Hormonal support is then given until the placenta takes over for the hormones. Sperm sorting is a procedure in which sperm are sorted and the desired sex sperm are used in insemination or in vitro fertilization. Why would we do this? Rationale include chromosomal abnormalities that are associated with one sex, or couples who have two or more children of the same sex and they have a strong desire for the other sex. There are ethical issues concerning this, particularly in the latter case, for couples who desire a certain sex child. This is not 100% effective. It's about 75% effective. So what would their parenting skills be like if they had the child and they were not the desired sex? So there are definitely ethical issues surrounding sperm sorting. A gestational carrier is a woman who is contracted to carry a pregnancy for a couple, and this pregnancy is genetically not her own. Typically, this would be in cases where a woman is able to produce eggs, however, she's unable to carry a pregnancy due to absence of a uterus. Either she was born that way or it was removed through hysterectomy, impaired uterine function, or a life-threatening medical condition. In some situations, couples may use a gestational carrier and a donor egg or donor sperm, but with a gestational carrier, the pregnancy is genetically not her own. A surrogate, on the other hand, is a gestational carrier and an egg donor. So genetically, this baby is hers, and she's acting as a surrogate, carrying the pregnancy in addition to that. With both of these women, there is an agreement that when the baby is born, it will go to the couple. So there are legal agreements drawn up prior to this. ICSI, or intracytoplasmic sperm injection, is micromanipulation. This is a specialized procedure where sperm quality or morphology is of concern. There are genetic concerns, or prior conventional in vitro fertilization was unsuccessful. What they're doing, if you look here at the picture on the right, or you can see on the monitor screen the picture on the left, they have the egg. The egg is the large blue circle. The sperm, look how much smaller it is. It's that tiny purple sperm coming out of the needle. They inject the egg with the sperm, hence the name intracytoplasmic sperm injection. So this is a specialized form of micromanipulation. Adoption is another possible solution for infertile couples desiring a child. Adoption can be a very time-consuming process that's very costly. It can be really a wonderful experience. It's a very emotional journey for both the adoptive parents and the birth mother. The decision to relinquish a child is one that is not lighthearted. Oftentimes, birth mothers can struggle with this decision. Birth mothers can be as involved or uninvolved as they want. They can set up the arrangement with the parents who will be adopting the child. So it can be an open kind of arrangement where they may, have visits or share letters or pictures. There can be an arrangement including any, none, or all of those things. Or it can be a closed adoption where the adoption takes place and the mother and baby are then separated. In addition, there are a number of ways the adoption can take place. Some birth mothers like to have input into who is adopting their baby. Others do not. So there are a lot of individual choices here. Our role as a nurse with these patients would be to counsel them about their options and then advocate for them to help them through this journey in a successful way. This concludes the infertility lecture. Please let me know if you have any questions.